Hi, my name is Jason Wasfy. I'm an associate professor of medicine at Harvard Medical School and cardiologist at Mass General Hospital. I'm also an associate editor of JACC, and we are delighted to have Vinay Kini here today, assistant professor at Cornell, and we have just published his really interesting paper about an area which is critically important to all of us who do health services research, but is really important, really, for anyone who practices cardiology in the United States. There's this tremendous consolidation of clinical practice and much higher proportions of cardiologists who are not working for themselves. They're employees of hospital systems. So we're delighted to have you here.
Thank you. Thanks so much for having me. It's my pleasure.
And we're delighted to have this paper in JACC. I think what really pops up to me, and we discussed this a lot when we were reviewing your paper and considering it for publication, is figure 1. It's really astonishing. To my eye, this shows in 2008, and this would have been when I'm a junior resident. I think you may have been, I think, about the same generation as me. The cardiologists that were not integrated, not employed by hospitals, it was like 70% across the whole country at that point, and less than 30 were employed by hospitals in 2008. And then over the course of your graph here, your study to 2020, it's almost totally reversed now.
Yeah, no, it's been a really fascinating transformation in how cardiologists have practiced and how that's changed over the last several years. And I think there are really 2 or 3 major reasons for why that shift occurred. So I think the first is that there was a strong incentive for hospitals and health systems to try to acquire some of these cardiology practices. And there are some reasons for that. One is that, as you know, and many listeners will know, is that Medicare in particular has something called site-based reimbursement. And so for the same test, for example, for an echo or stress test, Medicare will in some cases pay up to 40% more for a test that's performed in a hospital-based outpatient setting, as opposed to a physician practice. And in addition, hospitals can actually capture additional facility fees on top of those charges. And as you know, Jason, well, that there's been one of the other drivers for consolidation is that hospitals and health systems can bring more strength to the negotiating table with insurers, and they can ask for higher prices and they will get it. So for a lot of those reasons, I think we've seen hospitals and health systems really try to acquire independent practices. And I'll also say that that also has worked in reverse. I think we've seen that one of the unintended consequences of the Affordable Care Act is that the administrative burden on clinicians really went up. And, with increased quality reporting requirements, EHR requirements, for example, I think that many clinicians felt so burdened by it that they felt the need to kind of offload that and let larger hospitals and health systems take care of it. So I think for those reasons, we've seen this kind of incredible shift in the way that cardiologists have practiced in this country, like you said, since 2008.
So it sounds like, acknowledging the complexity of American healthcare financing, because we have different people paying for services, we have a mixed system. It sounds like, as has been well established, costs go up when this happens, right? Cost goes up for the reasons that you're saying, that Medicare, in many cases, you're invoking facility fees, the prices for what is provided goes up. In addition to the other issue, which is in commercial insurance, these larger organizations have more power to negotiate higher rates. So that's bad that healthcare costs are going up for the system, but there's presumably potential benefits too, that things are better coordinated, maybe quality gets better, maybe outcomes get better, and that's sort of really where your paper focuses. What do you find?
Yeah, that's exactly right. So I'll just say that I agree that it's been well established that prices and spending has gone up because of this trend. But what's been less well established is whether this has really improved care quality or outcomes. And theoretically, you think, it's plausible, right? Because there's more coordination between inpatient and outpatient care. Perhaps there's more resources devoted to not only care transitions, but also making sure that patients get the right quality of care. So we really wanted to delve into that issue. And so what we did was we identified those cardiologists who switched from independent practice to hospital-employed practice. And the way we did that was we used hospital tax ID numbers. So when cardiologists started using hospital tax ID numbers to bill for services, we knew that they had switched to basically direct employment. And so our study design sort of used cardiologists as their own control. So we assessed whether practice changed when cardiologists switched from independent to hospital-employed practice. And we assessed a variety of outcomes with claims data. So these were in-hospital mortality, 30-day mortality, 30-day readmissions, a variety of quality metrics, heart function assessment for patients with incident AMI and heart failure, 30-day follow-up visits, and we assessed a variety of utilization measures as well. And across the board, we really found no significant differences or no clinically meaningful differences in patient outcomes, in care quality, or in utilization also.
And so what would you recommend in terms of lessons learned for the health system? So this is sort of a sobering message, right? There's another literature out there that, as we're referencing, that costs go up. You're now showing that quality doesn't really get better. What should be done? Should some of these laws be amended? Should we all go back to doing smaller practices where cardiologists are self-employed and not employed by health systems? What do you see as a potential lesson learned from this work?
Yeah, that's kind of the million-dollar question, and I'd love to hear your thoughts as well. I think we know that prices and spending has increased, right? And so it's important for a variety of reasons for us to try to bring healthcare costs down, because it means that there's less money for other things in the government's budget. So there is legislation ongoing both at the state and federal level right now to try to limit what's called vertical integration, or affiliation or employment of physicians by hospitals. And I think that is potentially one way to bring costs down. But at the government level, this is sort of an antitrust issue, right? So these are the same types of laws that were used in the late 1800s to break up big steel, and they're using the same types of laws to look into healthcare. And I think all that has to be weighed, though, a little bit with physician practice, though, right? Because I think one of the reasons that this shift also happened was because of the increased administrative burden and physician burnout. And so I think those are root causes and important things that need to be addressed as well. And I think that voice certainly needs to be heard in this discussion.
Right. So your paper is primarily dealing with the quality of healthcare. There's an additional literature there about costs, but you're referencing additional things that need to be considered, which is sort of burnout and autonomy. I mean, just sort of my very basic understanding of this is that in moving from smaller private practices to being employees of large organizations and hospitals, we as physicians and cardiologists probably are trading off. Maybe life's going to get a little bit better. If you're in private practice for yourself, you're going to have trouble covering your pager and stuff like that. Going to a larger organization, we can make fewer decisions for ourselves and our practices and our patients. But the trade-off is that you probably have a big organization behind you to share some of these burdens and call schedules and malpractice insurance and all these costs that small private practices incur. What research do you think needs to be done to assess that? Like, what has been done to the cardiologist workforce in terms of engagement and burnout and those parameters?
Yeah, that's a great question. I think you nailed it hit the nail on the head. It was a trade-off between sort of that autonomy and independence versus having some support. And I think we need to know a little bit more about sort of specifically what those differences were and what drove cardiologists and other physicians specifically to, this employment model through being employed directly by hospitals and health systems. And I don't think we understand specifically what those things are, but I think that's important to know in particular as we kind of think about ways forward and how to, make sure that physicians have that appropriate work-life balance and aren't burning out and have not only autonomy, but also support. And so I don't think we've quite figured that out yet.
Can I maybe finish with a research methods question? One of the reasons we liked your paper so much is that, as you know, in health services research and health policy research, you at least almost never, not quite never, but almost never have a randomized experiment, right? This just happened and we have to control for secular trends and confounding. And this is always a big, difficult issue in health policy research. So you spent a lot of time with what I know to be really difficult work, sort of assigning people to tax identification numbers and making sure you understood who was who, and identifying this group of people who switched from non-integrated to integrated practice. But in this kind of research and the kind of research that I do, it's inevitable that you can say, oh, well, maybe there's something different about those cardiologists. This is never a solvable problem unless you're going to do a randomized control trial. Are there situations in health policy research where you think randomized experiments are needed, or should we always do this kind of quasi-experimental analysis to determine which policy is better than which policy?
Yeah, I mean, ideally we would have, a randomized trial for these types of things, right? Where randomization ensures that there's equipoise, right? And so you know well that with this type of work, we can come close to that by using a variety of methods. And so in this situation, I think we were lucky to be able to have a methodology which could overcome many, but perhaps not all, of these potential confounders. So one of the ways that we did that through our difference and differences analysis was that not only did cardiologists serve as their own control, but we had other control groups as well, right? So we had cardiologists who remained non-integrated or non-hospital employed throughout the study period. And then in our regressions, we used a variety of fixed effects. So we used cardiologist fixed effects and hospital fixed effects and calendar quarter fixed effects to try to control for changes over time in how AMI and heart failure care has changed. Hospital independent practice because things are done differently in different hospitals. And also cardiologists themselves. So in a way, we really tried to isolate the effect of the switch itself from all these other potential confounders. But you're right. You can never be, with observational data, you can never be 100% sure that you've done away with any potential emitted variable bias. So I think you kind of do the best you can with the data you have, and I'm lucky with our group to have some very savvy health economists and causal inference experts as well. So we did our best.
Sometimes when people say, oh, we should do randomized control trial, there's no way to fully solve these things. The point that I kind of often counter with is that if you did a randomized control trial, some health policy, the way that trials go, it takes a long time, it'll take many years. At that point, whatever result you get, the country will be in a different place in terms of what the patients need, or the healthcare financing policies and things like that. So that's another reason why I think we have to do the best we can with quasi-experimental methods to understand what policies are more effective than other policies.
Yeah, that's right. And I do think that I agree 100%. And sometimes that happens, and then you've spent millions of dollars on this trial, and then you have a result that may not be applicable. I do think one thing I would like to see is, CMS rolls out different payment models sometimes, right? And there was a potential for randomization a few years ago with one of the bundled payment models, and it went away. And so we're doing another evaluation now where we're using these types of methods again to do this policy evaluation. But boy, it would have been nice if if that had come out in a randomized fashion, because I think we can learn a lot from which policies are effective and which are not when things are done that way.
Right, that's a great point. Yeah, CMS can build it into the way that they roll out the policies, and I think we were all ready for that randomized experiment, cluster randomized experiment, but it canceled in the end, as you're referencing.
Right.
Well, anyway, congratulations. We are delighted to have this paper in JACC, and overall, I just am constantly, I know both of us do health services research. I'm constantly thinking about this idea that even if we never develop another technology or another medicine ever again, we probably still could improve outcomes for patients so much by simply organizing the system in a way that better meets the needs of our patients. And this kind of research is so critical to helping us do that. So thank you, Vinay. Congratulations.
Thank you, Jason. Yeah, it's my pleasure. And thanks for your interest and taking the time today.